Welcome to the Blueprint Podcast, where we throw out the old blueprint so you can become who you were always meant to be. I'm your host, Jason Smith, and if you haven't already, make sure you click the subscribe button and share this podcast with your friends on social media and tag me in it at JBirdFit. Today, I have a very special guest for you, Dr. Chris Frueh. Chris is a clinical psychologist by training and a professor of psychology at the University of Hawaii Hilo. He has over 30 years professional experience working with military veterans and active duty personnel and has conducted clinical trials, epidemiology, historical, and neuroscience research. He has co-authored over 300 scientific publications, including a graduate textbook on adult psychopathology. His work on operator syndrome is helping change the way we understand and treat the complex set of interrelated health, psychological, and interpersonal difficulties that are common downstream outcomes of a career in military special operations. Chris, welcome to the Blueprint Podcast.
Thank you. Excited to be here.
I recently came across your interview with Andy Frisella on the Real AF podcast, and your personal narrative alongside the insights from your book, Operator Syndrome, really resonated with me. I'm currently running a 12-week men's program where 4 out of the 6 members are current or former military members and first responders. Inside the group, I bring on therapists, coaches, CEOs, veterans, and others who share their stories and expertise with us. When I heard you give your views on the mental health industry, I was like, I got to have this guy on the show. I tend to interview people who are challenging the system and acknowledging there are other tools, modalities, and information that we should or can be considering. So, Chris, I appreciate you being on the show, man. Tell us a little bit about your background and what caused you to write the book, Operator Syndrome.
Jason, thank you for having me. I'm excited to be here. So I have a PhD in clinical psychology. That's my background. Earned that degree in 1992. When I went to graduate school, my father was a Vietnam veteran. He was a physician in the Air Force, not a combatant. But so as a child, I grew up, was a preteen and teenager in the 1970s. The Vietnam War was hanging over everything. And so I wanted to work with veterans. I wanted to help veterans with my career. So earned the PhD, went to work in the VA system. So I was at the VA Medical Center in Charleston, South Carolina, and also faculty there at the Medical University of South Carolina. And I was a full-time clinician for 7 years. That was really all I aspired to. Although I did a little teaching, I did a little research. And then that research got bigger, and then I applied for and received federal grants, and that kind of shifted my career direction. But I continue to be a therapist at the VA, not full-time anymore, but at least part-time in a PTSD clinic. I had some differences with the VA. Some of my work, some of my research was pointing to concerns about VA policies on disability and the way in which they were being adjudicated. Part of my concern was just the entire concern that we're paying people to be sick. How do they get better? And we paid people to be sick specifically with PTSD. We weren't attending to other aspects of what I now would expect are things we should have been looking at.
Yeah, it's almost like a blanket diagnosis of, you went to war. Yeah, PTSD. There you go.
Easy button. They're hitting the easy button with the PTSD. And that's all throughout our society. That's not just the VA. I see that everywhere I look. I left VA in 2006, moved to the University of Hawaii, the branch campus on the Big Island in Hilo. I've been here 17 years. Past decade or so, let me add this. I also had part-time work in Houston. So I was commuting to Houston every month for about 12 years, first at Baylor College of Medicine, then at University of Texas Medical School.
From Hawaii?
And so I had from Hawaii, built up a few miles over the years.
Yeah, I bet.
But in Houston, I had a circle of friends from the veteran community, and some of them were operators, and that kind of led me to where I am today in terms of having spent the last 10 years doing a lot of individual, personal consultations with operators. And so today, 2024, I've worked with operators from every branch of the U.S. service, military service, except Coast Guard. I've worked with Canadian SOF and a handful of operators from other countries, a lot of private defense contractors. And of course, in the private defense contractor community, you have essentially most of the people who are shooters were former military or former law enforcement. In 2020, we published a paper titled Operator Syndrome, a medical paper, scientific medical paper, just describing this pattern of injuries that I and my colleagues have seen, and really the whole care provider community for SOF has seen over and over again. And we call it operator syndrome. It's injuries, conditions, impairments, functional impairments that all go together. They're all interconnected. They all affect each other. So I'll just run down the list partially. So traumatic brain injury, which is caused in the military not only by impact forces but also by blast exposures. And then you have sleep disturbance and sleep apnea, endocrine problems. Low testosterone in particular is a real problem. Chronic pain, headaches, and then you get into the the official psychological issues: depression, anxiety, anger, PTSD, addictions. Then we have the injuries to perceptual systems, so vision, hearing, balance. All of these are typically affected by TBI. Cognitive impairments, again, affected by TBI, affected by poor sleep, affected by psychological problems. Now you can imagine all of this bleeds over into marital functioning, intimacy functioning. For soldiers, then all of this starts to accumulate, and then there's a point where they transition out of the military into the civilian life, and they get hammered there. Then we have the toxic exposures that cause respiratory illnesses, and we're seeing starting to see very high cancer rates. And then last, and of course, the existential concerns, whether we call it moral injury, guilt, shame, loss of tribe, loss of purpose, survivor's guilt. There's a lot of different names we can use, but this category is very prominent. And then you put all that together, and I don't consider this to be part of the syndrome per se, but an outcome of the syndrome, suicide. And we are seeing high rates of suicide in the special operations community. And so that's the framework of describing the syndrome. And of course, that's all the bad news. And then the good news is stuff that I hope we'll get into, which are the various things we can do to treat and to help and to improve quality of life and functioning. But even before we get to that, let me just say this is a framework for understanding the injuries and impairments that we see in operators. Since we published this in 2020, I've had a lot of contact, a lot of now work with firefighters, with law enforcement, and the framework works for other groups. And I'm even going to include some tactical athletes in there, career tactical athletes who I'm starting to have conversations with now. And before you say, I was in the military, but I wasn't an operator, so this doesn't apply to me. If you were in combat, if you saw extensive training with shoulder-fired rockets, demolitions, jumping out of airplanes, diving, if you were in urban combat at the tip of the spear, this is going to apply to you, and it's going to apply to other soldiers maybe who have lesser exposures, perhaps to a lesser extent. But the framework really is quite a bit broader than people who are formally defined as operators.
And so have you received any pushback on that from the people that may or may not have had those experiences as far as labeling it operator syndrome or it being
There's
something different?
pushback, yes, but not directly from soldiers per se. I can think of one neurologist, a handful of people who are PhDs or MDs within the VA, SOCOM, who have expressed concerns. There's a few officers military flag officers who have just said that they don't like it. I don't have a clear idea why. I have not yet had a real debate with critics, but I know those critics are out there.
Yeah, I think it's one of those things when you start challenging the system and putting information out there that doesn't coincide with the current narrative that's being expressed about what these injuries look like, what's actually going on, what's happening, both as a group and as an individual. It doesn't jive with what they're putting out there. So it's almost like an automatic response that we have to push this off to the side because it's very uncomfortable to hear this type of information and to recognize that, you know what, maybe we shouldn't be classifying it all as one thing and that it's actually a series or multiple things that are causing this to happen.
Yes.
And so we get to this place where it's, yes, you've got a diagnosis, now you're screwed for life because here's your diagnosis, this is the way it is. And I was hoping you could speak more on that in terms of what our veterans are facing with the VA and those type of diagnoses.
So part of my concern and criticism of the VA is I think they over rely on the diagnosis of PTSD. That is not a surprise because they've made PTSD compensable for disability. And it's not that veterans can't get disability for other conditions. Certainly, there are veterans who have disability for TBI, for physical injuries, chronic pain, sleep apnea, but they don't put it all together, and they're not treating these conditions as a whole. And so I'll come back to that fragmentation of care. But part of the problem with disability also is that the message it sends. If you're a veteran and you come to me and I'm the big VA and I'm saying to you, we're sorry, you have PTSD, you're never going to get better. We're going to send you a check every month for the rest of your life, and that will help. There's something tragic about that. There's really something tragic about that. We have good treatments. People who are not veterans, who are not in the disability system, get better from PTSD. That's not to say everybody gets better, and it's not to say that we have a way of resetting you to being the way you were before you went into the service or before you deployed. We can't do that. And I believe we owe every veteran who served that safety net, that help, whatever help they need. One of the things that, sorry.
No, I was going to say, can you define PTSD for us?
But I'm going to give you my definition. And part of this comes with a historical perspective. So PTSD as a diagnosis was first created and added to the psychiatric nomenclature in 1980. So prior to 1980, there was no such thing as PTSD. We had other names for things that resembled PTSD. We had combat fatigue, we had Vietnam syndrome, going back to World War I, we had shell shock, and going back to post-Civil War, post-American Civil War, we called it soldier's heart or DaCosta syndrome. So we've long known that warriors are affected by their experiences, and we can see this in Shakespeare's writings, in Homer's Iliad and the Odyssey, all the way back to the Epic of Gilgamesh. You see it in biblical narratives. The idea that warriors come home from war or come home at the end of the day after a shift in their own hometown, that there are lingering challenges and issues and concerns that's not new. That's not a surprise. That's to be expected. What is PTSD? The way we've defined it is it has several features, and we literally have 4 different categories of symptoms post-trauma. And just to break it down fairly quickly, one category are ways in which we re-experience the traumatic event through dreams, through intrusive thoughts, etc. Next category of symptoms is avoidance. So if you have fear reactivity to a sound of a helicopter that reminded you of your deployment to Afghanistan, for example, you might avoid helicopters or places where helicopters are more likely to be, just to give an obvious example. And that makes sense. That's a classic anxiety disorder symptom. Fear of something accompanied by avoidance of that thing. Makes sense. The avoidance, though, is actually what maintains the fear, because by avoiding, you never give yourself the chance, your physiological self, the chance to learn and habituate to it so that it doesn't stimulate that anxiety. So the intrusive, re-experiencing, the avoidance, then there's a category of negative emotions, negative thoughts, negative symptoms, anger, blame, self-blame. And then the final category is what we call hyperarousal. So just that sense of elevated physiological reactions. And so difficulty relaxing, difficulty concentrating, being vigilant, hypervigilant, having an exaggerated startle response, and so on. That's PTSD as we define it. I will give a simpler definition, which I think is pretty easy to defend. For me, if you deconstruct the symptoms of PTSD, what you end up with is you have a mixture of depression and anxiety, plus something unique. So it's a combination of depression, anxiety, plus the fear reactivity and the avoidance, specific fear reactivity. What I see with operators, now here's where I'm going to make things complicated. Operators and many soldiers will score high on a questionnaire. If you put a questionnaire in front of them related to PTSD, they'll score high. They'll look like they have PTSD. But when you really drill down into what's going on, they may have anxiety, they may have bad dreams, they may have depression. They tend not to have the avoidance. They tend not to have the actual fear reactivity. Most of the guys I work with will say, I miss it. I miss the action. I miss being a part of that life in that world. I miss the guys. And they do things that are the opposite of avoidance. They run to it. What are their hobbies? Oftentimes shooting, skydiving, rucking. A lot of people come out of the military and then they go on to either contracting or law enforcement or firefighters or other executive protection. I think it becomes hard to say PTSD is truly the root cause of the problems.
The question that often comes up is, if that's what's going on, then how can a former operator begin to get some sort of assistance or therapy or help in these areas, because they recognize that something's going on. They don't know what it is. It's been labeled as PTSD, but they, like you said, they're missing some of the components of that. And now they're not being treated the way that they should be. So what are some of the therapies that they can gain access to, and where would they be able to get that from?
Let's start with the VA, because the VA will make a psychiatric diagnosis and they will provide the traditional mental health care that we all think of. They will provide psychotherapy and they will provide psychiatric medications. Now, whether they're doing that effectively is another question, and whether they're tailoring that in a meaningful manner to the experiences and difficulties of each individual patient, that's another question. If I had a kind of a global concern about VA treatment, it would be several things. One is I think there's too much medication being prescribed. I spoke with a guy yesterday whose symptoms have only gotten worse since he started treatment, much worse. And when you look at his medications, he's on 4 different pain relievers and he's on 6 different psychiatric medications, including a couple for sleep. So here's a guy who went from having no medications to about, I think it was 11 or 12 just within the course of since January. And he's gotten much worse, much sicker. He's having blackout episodes in the middle of the day when he's not drinking or anything like that. So over medication is a concern. I also am concerned about the psychotherapy. Are the therapists in the VA, are they culturally competent? Psychology and social work, we like to throw that phrase around. Usually when we use the phrase cultural competence, we're referring to a therapist's ability to connect to somebody of a minority race, somebody of a different gender, different sexual orientation, or somebody with a very different sort of demographic life from the therapist. We don't talk about veteran culture or military culture or even branch or unit culture. One of the things I hear a lot from veterans who go in for therapy is they realize their therapist doesn't understand anything about the work they were doing, doesn't understand the magnitude of the training that goes into things. And that shows up in a couple of ways. One is that VA clinicians tend not to understand how much wear and tear there is on the joints. They tend not, from rucking and jumping and diving and running and carrying heavy loads. They also tend not to understand the impact of blast exposures. So TBI is primarily diagnosed with questions that are designed to something like this. How many concussions did you have that were diagnosed? Of course, we know most concussions probably aren't diagnosed because people are busy and they don't raise their hand. They tend not to ask about training with demolitions, breaching, shoulder-fired rockets, other explosives. They tend not to ask about the use of those in combat or the being on the receiving end of indirect fire. The understanding of blast exposures just isn't there and usually gets skipped over, from what I can tell. Now, this is all secondary to what people are telling me in terms of their own experiences. And then another piece of that is the therapists themselves are often, what's the right word? They have their own emotional reactions to what the soldiers say. So
Yeah,
one thing that I
because you're gonna share some things and they're gonna be like, "That does not compute in my world. I've never seen
that's
this.
right.
I've never experienced this. I don't know what it
That's
looks like. I don't know what it smells like. I don't know the sound. I don't know the feeling throughout my body somatically." There's just all this stuff, and they don't get it. They can't.
and you can up to a point enough to be able to listen and to ask the right questions. I've never been in combat. I never served, never put on a uniform. But I'm also not going to break down and be curled up in a ball, crying, sobbing on the floor after you get 10 minutes into telling me a little bit about your military experience. And that sounds ridiculous, what I just said, but I hear it over and over again.
Yeah.
I've heard that many times. In fact, I think I talked about this on the Black Rifle Coffee podcast recently, and somebody in the room said, "Yeah, that happened to me. That was exactly my experience." So that is and then what do? The soldier feels bad. I didn't come here to make my therapist upset, but now I'm realizing that therapist can't help me. So I leave and I don't come back. Now let's put this on responders. Soldiers at least have a VA. Soldiers at least have this great big monolithic federal bureaucracy that at least in theory stands for them.
Yeah.
It funds research. It provides clinics. It provides treatment programs. So even though those programs may not be perfect, may not provide everything needed, at least they're there. What do law enforcement or firefighters do? How do they find healthcare that's
Oh, you're on your
attuned?
own.
Yeah, you're on your own. One more thing about the VA, and this is something that I think will change. I mean, it has to change, but it hasn't really changed yet, is there now, and you alluded to this, we now have all these great treatments that are more than just psychiatric medications and therapy. We've got many other things in the toolkit, and we're not using them in the VA. The VA doesn't widely provide stellate ganglion block therapy. It doesn't widely provide ketamine infusion therapy. It's generally, from what I've been told, very resistant to testing for hormonal dysregulation. They don't want to go there. If they do go there, their standards, their thresholds, one could wonder whether they're the appropriate standards and thresholds to initiate care and treatment.
Yeah, it's so interesting because you would think that would be like the first line of defense, right? You're going over, you're having a survey, you're talking with your client, you're going through this conversation. We should probably look at your hormones. We should probably look at some of the basic things that are happening in your life right now to see just where you're at, because it does have a direct impact in the way that you think, act, feel, and then show up in the world.
We have Sigmund Freud to thank for this. I'm being a little facetious here, but not entirely. The mental health field, the mental health industry, they do what they do, and there's a massive blind spot for hormones. And one way that I can quantify this is I've been a faculty in 3 different psychiatric departments, which were large, over 100 faculty members, which were multidisciplinary: psychologists, psychiatrists, neurologists, nurses, social workers, geneticists, sociologists, neuroimagers. And then when you factor in the churn, if I'm in a department for 15 years, there's churn and turnover. So I don't know how many departmental colleagues I could say I have, but it's at least 4, 5, 6, 700. Not one endocrinologist in any of the departments that I knew of. There were some internal medicine docs who would think about hormones, but they were few and far between, and they weren't doing the research. So it's a blind spot for our field. And we can go back to, I blamed it on Freud. That's not entirely fair because Freud was a long time ago, but his view of mental illness was it's about things that happen in our childhood that are there in our unconscious. He put less emphasis on the physiological systems of the body. Whereas I think we should reframe our understanding of all mental illnesses to at least acknowledge there is a cellular and molecular basis. And one of those that we can now, I think we could acknowledge for all of us in terms of depression is inflammation. Chronic systemic inflammation is a factor, is a causative factor in depression and other psychiatric disorders. And we don't talk about that. We don't do enough even to just simply address that.
And if you mention it, you almost get ostracized. They immediately push you down. You have new guidelines on men's mental health and what that looks like, and then how we're treating our young men and boys that are in therapy.
So that's a whole other new, huge
Yeah.
challenge.
And so what are your thoughts on that?
Oh, fuck that.
Exactly.
The Quillette, yeah. So yes, Quillette magazine a few years ago, and this is a heterodox intellectual magazine that wouldn't be widely known to people, but they had a special issue. I think it was 2018 or 2019, and I was one of the contributors to. They had 12 scholars write short essays in response to the American Psychological Association's guidelines for therapy with men and boys. And I'm not going to get in too deep into what those guidelines were, but essentially they were saying that a huge part of the problem for men and boys is the toxic masculinity and all the things that go with that. And how are they defining toxic masculinity and what are the implications of that? And a lot of us read their guidelines as suggesting that we need to be training boys and men to be more emotionally expressive, which may or may not be okay, that we need to help them get in touch more with their feminine side. Seems like there's an emasculation effect going on by the modern day mental health care industry. And you have to also keep in mind that when you look at the world of therapists, they are now primarily females. There are very few men, relatively few men, going into doctoral and master's level programs for therapies. There is this ideological drift that has occurred within psychiatry and psychology. It's become very progressive left wing, and they're now taking that and putting those into practice with boys and men and others. I've got a close friend, and I'm going to be careful here, but I've got a close friend, a young man I've been working with for several years, who's at one of the tier units in the military, and he's taken some master's courses in psychology. And one of the things he's being confronted with are white supremacy, the male patriarchy, and microaggressions. So here's a guy who's been overseas many times, doing very dangerous, very adventurous activities on behalf of protecting his nation. And he comes home and he's the only male in his class. He's told because he's a male, he's been privileged his whole life. No, his childhood was completely FUBAR. He was homeless. He was on the streets. He was running with gangs. Nothing privileged about his childhood. Yes, he is a man. Yes, he is white. But to blame him for all the ills of society for those reasons, which is what he's feeling is happening in the class, is unreasonable and unfair. And then you get into the concept of microaggressions. So here's somebody who's literally been in hand-to-hand combat with people who want to cut his head off. And he comes home and he's told that the biggest problem and one of the big problems in American society is microaggressions. And just pause on that for a moment. People ask me where to get a therapist. And here's what I say to people. Therapy can make a huge difference. Psychotherapy can be profoundly beneficial. I am not at all a critic of the concept, but God bless you. If you need to find a therapist, I don't know where to send you. I do in some places, but finding a quality, trained, humble therapist who's willing to be curious and learn about you and your experiences is very difficult. Oh, the Afghan withdrawal. We could have an entire podcast on this. Where to begin? I think, first of all, we fought a very effective war there initially, and that's perceived by, I'm not speaking from a historical perspective, I'm speaking from the perspective of the operators I work with. We were there a long time. We invested a lot of blood and treasure. And the appearance for many in the military community is that we very abruptly pulled out without a good plan. In the process of doing that, we forfeited all the blood and treasure we've lost. We forfeited more than that because we left behind a lot of material that was picked up and has been used by the Taliban. We left Americans behind, which is disgraceful. We left Americans behind and we don't even talk about it. And we don't even know how many Americans we left behind. We also left behind and essentially betrayed our local allies. And that's something that gives the operator community an enormous amount of angst, anger, grief, dread. I have operators who will tell you that interpreter was my brother. He stood beside us. He fought with us. He got injured with us. He ate with us. He showered with us. We lived together. He was a brother. And then we abandoned him and his family, and we believe that he's now going to be murdered by the Taliban. We also have the perspective, which is horrible. And so post-exit, there were operators in the U.S. working around the clock for months to help bring Afghans out, to help bring Afghan specific individuals and their families out. And some of that was successful. Some of that worked. And I know there are still Afghans almost 2 years later, almost 3 years later, who are still moving around from safe house to safe house in Afghanistan. They can't get out. There are Americans who are funding care packages, grocery packages to feed them as they move from safe house to safe house. So there's a lot of angst there. We know, the military historians are now telling us, we could have held Kabul, we could have held the country with a pretty small force, with the right mix of aviation and intel and technology and a small number of boots on the ground. So the question that a lot of veterans have is, why did we break and run like this? Why did we do such a horrible, disgraceful job of breaking and running? Why couldn't we have taken, if we had to leave, we could have taken more time and done it in a more effective way. And by the way, I've done evaluations with private defense contractors, some of whom are interpreters. So in the weeks leading up to the abandonment of Kabul, I evaluated several individual Afghan interpreters who were still living in Kabul with their families, and the fear in their eyes and in their voices and in the content of what they were saying was just absolutely palpable. This was 4 weeks, 6 weeks, 8 weeks prior to Kabul falling. They knew what was coming. They were telling me, it's Taliban right down the road. They've got a checkpoint. I can go up to the roof and I can see it. That kind of stuff. So everybody who was there knew it was coming. Everybody knew what was about to happen. The contractors who were the shooters inside the gate, they knew what was coming. The contractors on the outside of the gates knew what was coming. We weren't told of the chaos very well. We know that 13 Marines were blown up at Abbey Gate, but we weren't told of the firefights that had been going on through the night. I didn't see much reporting on that, but there were chaotic firefights going on the day before we finally pulled out, and all night long. The day those bodies were falling off the airplanes, we had troops in contact. We had contractors in contact with the Taliban at the end of that airstrip. Those bodies were landing on their positions in some cases. And so from the veteran perspective, it's completely and utterly demoralizing.
Yeah.
They feel betrayed by the government, by some of the higher up officers, not the officers on the ground there. They feel betrayed by the State Department. A lot of anger at the State Department. State Department up until the very end kept saying, no, everything will be fine. The Afghan government will hold. So now we have a problem. What are you going to do as a veteran if you're feeling and having these perspectives? Are you going to encourage your children to recruit, to enlist in the service when they become of age? You're not.
Nope.
And veterans have been the best recruiters we've ever had in our nation's existence. You can see it. Military service runs in families.
And families.
So now they run in families. And now you've got an entire generation of soldiers and warriors who are telling their kids, I don't think you should enlist or commission.
There's an overwhelming sense of responsibility in knowing that you could have potentially done something different and had a major impact on that whole entire scenario, and then to not be able to see that come to fruition and then have to go home with that and carry that with you. I can't imagine how difficult that actually is.
And when you look your interpreter in the eye and said, we're brothers and we're here together, and then you get rotated home, or you go home and they're still there, and then your promises are undermined by what the government does. I mean, that's
now your own personal integrity has been impacted.
Yeah. And I think that's why so many worked so hard, literally running in shifts for months. There is an effort ongoing right now. It's sensitive, so I'm not going to say too much of it, but we have not stopped trying to get our allies out. That effort does continue in some places at a lower scale, but we are bringing people out
That's good to hear.
on a slow and gradual basis.
Let's get back to your book real quick. Who is the book Operator Syndrome for?
Okay, so this is the book right here. Thin, read it on an airplane. The book is for operators and their families, their spouses. The book is for other soldiers and warriors who may not formally be operators, but have similar patterns of experiences and injuries and impairments. And the book is also, although it's not titled as such, I think the book is very relevant to responders, first responders, law enforcement, EMT, firefighters. And I am an academic. I have a textbook that I've written, co-edited. This is about 900 pages of very dense words this is a graduate textbook on psychiatric disorders for doctoral and master's programs.
And over 300 other publications, right?
I have over 300 scientific publications. This is not a scientific publication. This book is intended to be a practical guide. I wrote it for the community so that, really for several reasons. One is as a vehicle to do what I'm doing now, to get on podcasts and be able to put the word out and talk with people and share some of my perspectives. Another purpose of the book is really just so somebody could pick it up, read it, and go, aha, now I have a much better understanding of what my husband or what my father or what myself is experiencing. And also, half the book is about treatments, lifestyle adjustments, approaches to seeking care. So it's really intended to be a very practical guideline. And it's not a dense read. It's written in a very informal, kind of conversational style. So I want people to be able to read it and follow it. There's not a lot of references in it. There's not a lot of specific scientific studies mentioned in it. And I had a lot of help writing the book. Throughout the book, every chapter, and sometimes sprinkled throughout chapters, are direct quotes from relevant people. I have over 40 different operators represented, and
Nice.
at least, I don't remember, somewhere between 10 and 15 spouses, as well as probably another 10 or 15 people who are providers or scientists working within the community. So I wrote the book, but probably almost a quarter to a third of the words are the words of others, which I did that with the idea of my words, who am I? I'm not a soldier, I'm not a responder, but the voices of those who are throughout the book. And I want to just thank and tip my hat to everybody who rogered up with a quote, because they did so with their names and their bona fides. It's not, I think there's a couple of anonymous quotes, but for the most part, it's Tom Satterley, U.S. Army Command Sergeant Major, Special Forces, et cetera, et cetera.
Chris, I can't thank you enough for sharing your time with us today and writing the book Operator Syndrome and putting it out there for everybody to be able to get a hold of that. Do you plan on throwing that up on Audible?
It's not in the works at the moment.
Okay.
And in part, need to have some conversations about this because I get asked this question all the time. Clearly, that would be another important way to get this out there. So
I know people with my brain, we appreciate the Audible aspect of it.
There's the coloring book that's coming out and the pop-up Operator Syndrome book for you, Jason.
Yeah, I appreciate it.
The only challenge, yeah, I'm kidding, obviously. The only challenge with the doing the Audible version is there's all these different voices in there, men and women. And to do it right, I think I'd need at least I need another man and another woman to read all those quotes, which isn't impossible, but it's just a lift I haven't been able to make.
Time consuming for sure.
Yeah.
Chris, where else can people reach out to you?
I'm on Instagram. I have a website, chrisfrueh.com. My email, I'm getting hundreds of emails every day, so I'm having trouble keeping up with the emails and the calls and the texts. I do work with and through a number of foundations. So probably the foundation I work most with is SEAL Future Foundation, and I chair a health board of advisors. There's 15 of us, multidisciplinary. Probably the best thing one of the cool things that we've done is we've created an educational platform. So if you were to go to the SEAL Future Foundation or even just do a Google search on the Operator Health Index, you'll find all this educational information that we've put up on their website. So that's definitely a good resource. My website, you can find the original medical paper. You can find the operator syndrome one-page scale, one-page questionnaire that you can download and use. It's also in the book. And you can probably just find these things anywhere on the internet because they're floating around out there. And one thing that I encourage people, you're going to have to educate your doctors. So starting with your primary care doc, you can take the medical paper, you can take the operator syndrome scale, show it to them and say, listen, I need a sleep study. I need to have my hormones checked. I want a consult with regenerative medicine about my pain. Maybe I do or don't want traditional mental health therapies, but how about a referral for stellate ganglion block, for ketamine infusion, for hyperbaric oxygen therapies, for transcranial magnetic stimulation, to a clinic that help people with diet and lifestyle. Changing diets and taking on an anti-inflammatory lifestyle can be profoundly beneficial in and of itself. So get out there, find those resources. They exist. They're just hard to find.
Yeah, I totally agree. It's never just one thing that's going on, and so you have to look at the whole person as everything that's going on with them, and then start to treat the different things that they're experiencing. And a lot of that can be done through your own habits and behaviors, which I think is pretty damn cool. So Chris, thank you so much for being here. Everybody else, go to his website, check it out. Make sure you read the different case studies that are there and interact with his content on Instagram. And be sure to get his book, Operator Syndrome, wherever you buy books.
Thank you, Jason.
Chris, thank you so much, man. I appreciate it.